So, good afternoon, everyone, and welcome to Agilus Diagnostics Med-Gurukul session. The topic today is on newborn screening, and it is my pleasure to introduce the speaker, Dr. Mayank Nile. Dr. Mayank is a senior consultant in genomics with Agilus Diagnostics. He's a pediatrician of 10 years of experience, following which he followed his passion of medical genetics. And now he has been working in medical genetics for more than 5 years. He has been assistant professor in the Department of Medical Genetics at the Postgraduate Institute of Child Health at Noida, also at the Department of Medical Genetics in SG PGI-MS Lucknow. He's done a senior residency from Maulana Azad Medical College. His areas of interest include lysosomal storage disorders, dysmorphology, inborn errors of metabolism, neurogenetic disorders, oncogenetics, and NGS sequencing and fetal medicine. So, Dr. Mayank, would you please start your presentation? As always, questions can be put on the chat and they will be addressed by the speaker at the end of the session.
Thank you, ma'am. Thank you for this kind introduction. And at the outset, I would like to thank Agilus team and especially Mr. Farashad Khan for such good academic sessions in which we doctors from different parts of the medical science are going to share our knowledge. So today we have decided that we are going to enlighten our team on newborn screening. Now, most of us, I think, who are from the biochemistry background or even from the pathology background, do have a knowledge about newborn screening. I won't be dealing with certain new things for them. But again, today I'll also discuss a little bit about next generation sequencing for newborn screening, which is a very new thing which has come up in many countries. And even in India, people are opting for it. Now, I'll try to share my slides. Hope my screen is visible.
Yes.
Yeah, thank you. Yeah, so before I begin the presentation, I just say, which I say every time, this is an era of reproductive genomics. Now, why I mean by this is that because whenever we are discussing reproductive genomics, we not only deal with a couple, but we also deal with the fetus and the future baby. So, of course, whether it is carrier testing, whether it is non-invasive prenatal testing for various chromosomal or genetic disorders, or even if someone is going for a pre-implantation genetic diagnosis for an IVF, we sometimes somewhere forget about newborn screening. So even for obstetricians, pediatricians, and we as a lab, we should make aware the people regarding newborn screening and the importance of that. Now, I have kept a few pictures in my first slide. You can see all these children were referred to me in last, I think, 1 to 2 years when I was at PGICH Noida with various diagnoses. Like most of them were referred to me as query Down syndrome. Some of them were referred to as query mucopolysaccharidosis, Hunter syndrome, something like that. But sadly, when I examined these children and got certain basic tests, 3 of these were having hypothyroidism. This baby, second, this 4th baby, and this 5th baby. Now, why I have kept this slide? Because it really pained me that a child around 11 years old, especially this last child, hope my cursor is visible, he was devoid of this diagnosis by I don't know what was the reason. The pediatrician lacked that thing or ignored that thing. A simple TSH test helped us in identifying him to have a hypothyroidism, and though clinically he was having most of the features. Now, why this is painful is that this child is already around 11 years old, and you all know that the treatment of hypothyroidism is very cheap. It is just a thyroxine supplementation. So depriving a child of that thyroxine for 11 years, I feel, is a crime. And sadly, most of these neurological deficits are irreversible. Though we started all these 3 children who are diagnosed with hypothyroidism or with thyroxine supplementation, but yeah, especially this child around 2 years old, and he was also around 2 years old, they picked up, but still the irreversible damage which has occurred to them, we cannot reverse that. So where lies the pitfall? The pitfall lies here is depriving them of a basic newborn screening. So here comes the role of a newborn screening, which can be done for basic 5 or 6 conditions, and also the extended newborn screening, in which various inborn errors of metabolism could be diagnosed so that an early intervention can be planned, and these children may have a normal development and normal future life. Now, what is newborn screening? Basically, it is just a system to identify certain genetic problems which are a health issue for the community, and overall which may affect the development and metabolic background of the child. A little bit about the history of NBS. It is started quite late in our early decades of the 1930, and one doctor was there, Dr. Falling, who identified PKU as an inborn error associated with mental retardation. He started a very simple ferric chloride test. Later on, in 1960s, Dr. Guthrie, he started the filter paper test for PKU. He developed a very simple, inexpensive test, which was a bacterial inhibition test. And surprisingly, this was a great success. And in 1960, it was taken up as a program in whole New York to screen all children with phenylketonuria. So you can see how behind we are. It started in 1960 in New York, and we are now around 2023, and still we don't have a universal phenylketonuria program in our country. So it pains me. So moving up to the next slide, there is a certain criteria for screening. Now, we cannot screen for everything. Around 8,000 to 10,000 genetic disorders are known. Do we need to screen for everyone? No. There is a criteria called a Wilson and Jungner criteria, which was given in 1968. It has certain points to decide for a disease to go for a screening or not. First, it should be an important health problem. Second, the diagnosis and treatment facility should be readily available. There should be accepted cheap treatment. And of course, we should be able to detect the condition in latent and early asymptomatic state. And again, it should be acceptable to the population. And of course, natural history of the disease should be known, and it should have an agreed policy on whom to treat as a patient. And of course, cost of case finding should also be feasible, and it is a continuous process. This is a basic NBS system. Like the birth facility, the blood is collected on a filter paper. There are certain field individuals who transmit it to the lab. The lab checks the metabolite levels through assesses it with various databases, and the results are given to the doctor. And then there comes the role of the medical team to track the family, to track the child, to go for certain confirmatory tests and start the treatment. So it is a teamwork. Now, what are the components of NBS? Of course, education. We need to train the professional, parents, and policymakers. Screening, of course, already discussed. Follow-up is very necessary. It shouldn't be like that कि हमने diagnose कर दिया बस ठीक है हमारा काम खत्म. No, we should keep following up the children whether they are properly compliant to the treatment or not, or what are the constraints or the response to the therapy. And of course, diagnosis, management, and evaluation is a long-term thing. Now, what are the benefits? The benefits are, of course, an early identification so that an early intervention can be planned. It is going to reduce the mortality and, of course, the morbidity, and it can also help in family planning and preventing that disorder in future children of the family. Of course, anything has certain risks, and NBS also carries certain risks like a parental anxiety. Sometimes we may get a false positive result. We have seen many times a newborn in NICU with a sick condition, something like a failure to thrive, not responding to feeds and all. We get a TMS, GCMS, and we found that, okay, glutathione carnitine is high. So it might be glutaric acidemia. We even start all the metabolic sick program, all the treatment, everything. And later on, the genetic testing is showing it to be a normal child, and he is also responding. So of course, there are chances where certain false positive results may come, especially on the extended NBS, because the metabolite levels may be affected by prematurity, sepsis, and various other organ dysfunction. Also, there are chances of a misdiagnosis or false negative. And then comes the ethical aspect of the right not to know. There can be certain individuals who may say, no, we don't want to know the results. And of course, certain unanticipated outcomes can also be there, especially the disorders which may be asymptomatic initially, but may present certain symptoms in future. So we should be ready for that. And that information should be given as a part of pre-test counseling. And of course, the risk of getting labeled diagnosis of benign conditions. Now, timing of testing is very important. There are already various guidelines, but generally between 24 hours to 7 days of life, it should be sent. And the ideal time is 48 to 72 hours after birth. Suppose if because of any reason, if the child is tested within 24 hours of age, a repeat testing should be done within 5 days. And if the baby is more than 5 days old, screening is still available. In fact, for Agilis also, we have different test codes for that. Certain special considerations, especially prematurity. Ideally, if a newborn is less than 37 weeks, we should collect the specimen at 5 to 7 days of age, and we should clearly indicate on the NBS card that it is a preterm sample, because they have a very high chance of a false positive result. Sometimes newborns are on total parental nutrition, which may also affect the level of the amino acids and organic acids. Transfusion is also very important. Sometimes the children the newborn may be transfused because they may have a very anemia in a very early neonatal age. In that case, also the TMS GCMS result may affect. Certain guidelines tell that after a transfusion, at least we should wait for 1 month, and some guidelines even say for 2 months. Suppose if we have not sent the DBS sample. And early discharge is also an important thing. If some family is getting discharged before 24 hours, we should do counsel the parents that a repeat sampling should be done. In this slide, you can see the area of the hill where we need to prick. These are the medial and lateral borders. A simple stellate can be, after cleaning, it can be used to prick, and then 5 circles need to be made on the DBS card, which is a very easy thing, and we can train the technicians. So what is basic NBS? Basic NBS or newborn screening is done commonly for hypothyroidism, adrenal hyperplasia, G6PD, galactosemia, biotinidase deficiency, and many labs are now doing for cystic fibrosis as well. Now, why these 6 conditions? Because an early diagnosis is certainly going to help the children. We can start the child on thyroxine. For CAH, they can be started on fludrocortisone and the other steroids. And G6PD, of course, a newborn who has a prolonged jaundice, is not responding, and he has a persistent liver dysfunction in NICU. And we may find that the child is G6PD deficient. So we can take certain precautions. If we have started certain drugs, which is leading to hemolysis, we can stop that. Similarly, for galactosemia, if we diagnose at an early age, we can prevent the irreversible damage to the liver and the brain, and just by doing a lactose-free diet. Similarly, for biotinidase deficiency, it may result in seizures, mental retardation in future, and simple biotin supplementation will prevent that. Also, for cystic fibrosis is a multi-system disease. It may involve our lungs, it may involve our gastrointestinal system, and an early diagnosis is surely going to help the family because we may start an early treatment. Now, there were certain studies in India. For example, the study 1988 by Dr. Radha Ramadevi in Bangalore, and similarly various ICMR studies and multicentric studies. And it was found that apart from these basic 5 or 6 conditions, newborns may have certain other disorders like homocystinemia, hyperglycinemia, PKU. All these were diagnosed, and it helped in treatment. They were started on certain supplements, and those children were doing quite well. Similarly, in the 1991 study, you can see 65 out of 1,314 patients who were having mental retardation were attributable to metabolic disease. Now, what I mean to say is that there are a lot of inborn errors of metabolism, whether they are related to amino acid or fatty acid metabolism, in which the deficiency may lead to intellectual disability. So if we diagnose them at an early age, we can start a treatment and we can prevent that mental retardation. Now, what is an expanded NBS? By expanded newborn screening, I mean to include the conditions of the inborn errors of metabolism, which are around 50, the 3 hemoglobinopathies, sickle thalassemia and sickle beta thalassemia, certain endocrinological disorders like hypothyroidism, CAH, metabolic disorders like CF, galactosemia, biotinidase deficiency, and I have also included hearing loss screening and screening for critical cardiac illness and an eye screening. These are very easy to do and can be done in a nursery setup. For hearing loss, we can just do an autoacoustic emission, and especially the critical cardiac illness, you just need a pulse oximeter to check for a newborn the preductal and postductal oxygen saturation, and you can at least predict if the child is having a risk for such illness. Similarly, for eye screening, it can be done by a simple ophthalmoscope to see the red reflex. So this is basic things which need to be done in an expanded newborn screening, and ideally this information should be given to all the newborns and the families. Of course, all these things can be detected. I think I've already discussed. Now, what is a screen positive? This is very important. Sometimes when the screen positive comes from TMS or TMS, then the doctor may ask us, sir, blood spot pe positive aaya hai, aage kya? So screen positive means further testing is required. We need to confirm this because these are screening tests. It doesn't mean that the infant is affected. So what can we do? We can directly measure the plasma amino acid analysis. For example, if there is certain disorder in which certain amino acid is found to be low or high on the DBS kit, we can directly measure that. Apart from that, we can also do the urinary GCMS analysis. This will help us in ruling out the false positive cases. This is a simple setup for the punching of the cards. I think already present at our Mumbai lab. Now, there are various technologies in screening like immunoassays, enzymatic assays, time resolved fluorometry. With time, certain new techniques have come which have really improved the success of this NBS program, and tandem mass spectrometry is, of course, the best one. Immunoassays have been traditionally be used to see the specific protein binding assays and that rely on the specificity and affinity of the antigen and antibody binding, and still performed for thyroid TSH in most of the cases. In this slide, I've just shown the microtiter plate or the slide footprint. This gives result very rapidly. Now, this is very important. Now, what is tandem mass spectrometer? Why we use the word tandem mass, or sometimes you may see a MSMS, because there are two mass analyzers, mass analyzer 1 and mass analyzer 2, and mostly we just separate the chemicals or the molecules on the basis of mass by charge ratio, and this is very helpful to detect the amino acid profile, acyl carnitine profile, and all those issues. Like conditions which help us in by this technique. For example, a newborn with hypoglycemia, coma, seizures, or history of cardiomyopathies, this can be fatty acid oxidation disorders, and all this can be picked up by an MSMS. Similarly, a child with severe metabolic acidosis, lethargy, respiratory distress, recurrent metabolic crisis, who is not responding to treatment, they can be having this branch in amino acid disorders. Similarly, I already told before, mental retardation, hyperammonemia, failure to thrive, all these can be a part of aminoacidopathies. Now, I'll just discuss a little bit about the burden of genetic defects in India. Though very large scale population based data is lacking from our country, but still the studies which have been done, they are alarming. Every year, around 5 lakh children are born with congenital malformations, 4 lakh children are born with G6PD deficiency, 10,000 are born with thalassemia major. Though there were large programs by the government of India and the ICMR like Jai Vigyan program, and even obstetricians, they are continuously counseling to get a thalassemia screening of couples by NHPLC, but still you can see such children are getting born. So there is some lack on the part of the policy makers and lack on part of us as doctors. We need to spread this awareness. One good thing has been done by the government of India recently, that sickle cell eradication program has been started, and surely it is going to help. And lastly, you can see 10 to 15% of pediatric admissions have some genetic etiology. So as I say in all my presentations, this is the era of genetic disorders, and this is the era of human genetics. And with new treatments coming up on the pipeline, we should have a high index of suspicion, especially when the common causes for an illness like sepsis and all are ruled out. Avoid a need of NBS program in India, because everywhere you can see in outside world, Europe, US, around 50 metabolic conditions, they are mandatory for each newborn. And of course, for us, cost constraints are a big issue, but still there is time we should start thinking on that. WHO has recommended that genetic services should be introduced in any country if the infant mortality rate goes down below 50. With good use of antibiotics, good diagnostic techniques available, of course, the morbidity and mortality due to infections have decreased. And you can see the infant mortality rate of India, as per the 2022 data, it was around 28. So now is the time to think for genetic disorders and start screening. And in India, though, the things which can be done very easily, they include screening for hearing loss, congenital hypothyroidism, CAH, and G6PD. Most of the states in India, like Chandigarh, Delhi, Kerala, and certain other government institutions have started free of cost screening for these at least basic 5 and 6 conditions. Also, the National Neonatology Forum has given a category A, B, and C, and they have categorized the different disorders into these categories, which may be helpful for screening. Category A, which can be and which should be offered to all newborns, is of course those basic 5 conditions. And especially northern states where G6PD is high, and sickle cell and thalassemia, which is also high in northern and eastern parts of India, those should be advocated. Now, what is category B? Category B, or high risk screening, should be offered to those families who have a high risk of such disorders or metabolic disorders. If there is a history of consanguinity, whether it is North India or South India, consanguineous marriages are common. And even we are having same caste marriages or so much of endogamy. So there are chances that recessive disorders will come up, and we do see. a history of previous children with unexplained intellectual disability, a history of a child with a seizure disorder, an unexplained sibling death in the family, or a critically ill neonate who has signs or investigations which are suggestive of inborn errors of metabolism. For example, a sick neonate with a high lactate, high ammonia, persistent metabolic acidosis. All these things are certain red flag signs. We should come in our mind that, okay, this is the time to screen for the inborn errors of metabolism. And of course, these are the fatty acid, amino acid oxidation disorders, PKU, homocystinuria, and most of these have treatment and easily available in our country. Now, category C. Category C is like for resource rich setting, or in fact, if a couple is affordable, then ideally we should give them an option for expanded newborn screening. Already I told you these include all around more than 50 disorders related to our metabolism. Now, various incidents of various disorders like hypothyroidism, G6PD and all were found in India by a study by a genetics group. And you can see it is quite common. Like for hypothyroidism, some pockets it has been found to be 1 in 1,000. G6PD also is very comparable to that. So screening is definitely going to help. So what are the issues standing in the way of universal implementation of NBS program in India? Of course, awareness, still it is lacking, cost issues. We need certain advocacy groups. We as lab, we as doctors, even patient support groups, and of course, policy makers will have to come in that. Awareness, and yeah, most of the cases, even many pediatricians and neonatologists, I have already told many times that most of the IM are misdiagnosed. Many times in small tier 2, tier 3 cities, they will be tagged as a birth asphyxia or a case of neonatal sepsis, irrelevant use of antibiotics, and of course, it is not going to help us. So current status, of course, most of the states have already put up the plan. I have already told this. Now, what are the suggestions? Certain suggestions is like that. We can have two types of models. One is a point of care model and the other is a central laboratory model. Some of the Indian states, they are very large. Their population and the, or you can say the area is large as compared to many countries. So for such states, we can have multiple central laboratories which can do the testing. Apart from that, as cost is an issue, manpower and resource application is an issue, the government can start a PPP model where the private partner can be involved with the states and both of them can start the screening. Also, ASHA workers are there. We have already in our MBBS books that there are accredited social health activist ASHA workers who are helping the child for nutrition, getting mothers for vaccination, and helping them in an institutional delivery. Why not involve the ASHA for a newborn screening? Because they are near to the families, near to the patients, they can sensitize them. If we can train them to for certain signs and symptoms, so that they can bring the child for newborn screening and they can get tested by a simple DBS card. Now I'm going to discuss about the next generation sequencing in newborn screening. Now, what is the advantage of next generation sequencing? By next generation sequencing or NGS, I mean, it is just, you can understand, it is simply the sequencing of the genes in our chromosomes, which can help us in identifying the molecular basis of the disorders. We are all doing NGS for various disorders or symptomatic people, but here I am talking about NGS in an asymptomatic or a supposedly healthy newborn. What are the advantages? First, before going to the advantage, I'll say that disadvantage is cost. Still, it is not as cheap as an NBS, but of course, if any family is affordable or if we can manage certain panels which are cheap, we should offer them because it is helping. It is going to help us in predicting the disorder, preventing, and personalized treatment. And the other advantage is it will directly detect the genes because DBS and all are detecting the metabolites. And the other thing is same thing. It is time independent. It can even be done antenatally on a prenatal sample. It can be directly done on the sick neonates because I told you initially sick neonates, false positive or false negative results may come on DBS. So in that case, genetic testing is going to be paramount important because it will just give the direct mutation. It is not affected upon the condition of the child. And what is an expanded NBS using NGS? We can include conditions like neurofibromatosis, Duchenne muscular dystrophy, spinal muscular atrophy. Now, why have put these disorders? Because these disorders have treatment available at present. And the crux is that if an early diagnosis is made, then only this treatment will work. Whether it is the gene therapy for SMA or the nusinersen therapy or the oral risdiplam, the main exclusion criteria is a delayed age of diagnosis. So we can, even many countries outside India, they have made SMA screening as a compulsory part of newborn screening. So these are the advantages of a genetic test. And of course, we need to decide a diagnostic test. A timely rare disease diagnosis is going to prevent the cost and distress associated with an extensive diagnostic odyssey. I've also kept a case scenario in which I will show you how a child who was deprived of genetic testing or newborn screening, he went to various doctors, lot of irrelevant tests were done. And of course, it led to wastage of the money and of course, delay of the diagnosis. And some disorders which can help us which can be detected by NGS, like Smith-Lemli-Opie syndrome, disorders of glycosylation, Wilson disease, and all the like, especially lysosomal storage disorders. They have also enzyme replacement therapy available in India, and though it is costly, but with the help of ESI hospitals and the National Rare Disease Policy, many of these children will have a free access to enzyme replacement therapy, which is going to prevent the irreversible damage. For example, Hunter syndrome or a mucopolysaccharidosis, the typical course phases generally comes around 4 to 5 years of age. So that is going to delay of diagnosis. But if we diagnose it through a NGS program, we can start the child on an early enzyme replacement therapy, and so the complications can be prevented. Now, what are the challenges of NGS at population level? Population screening is the only way to determine the true prevalence of a disorder. And it is required to understand the complete relationship between the various biomarkers and expressions. But of course, India has a large population, so we can develop certain pilot programs with the aim of improving the knowledge between the genotype and phenotype. And of course, it will also help in determining the prognostic value of the variant identified, because you all know in genetic testing, many times we are getting a variant of uncertain significance, which needs a lot of testing and further testing, including functional testing, to decide whether it is a likely pathogenic or a benign condition. And then the other challenge with next generation sequencing in NBS is regarding late onset disorders, because the genetic testing can also help us in knowing certain late onset disorders like retinitis pigmentosa, Alzheimer's disease, certain cardiac disorders, certain hormonal disorders. Now, that has certain ethical issues. Like some individuals may say, okay, this will violate our right of individual to not know. They may have a certain negative emotional aspect on us, because if we come to know that, okay, I'm going to suffer this Alzheimer's disease in my late 50s and 60s, this may destroy my late 20s and 30s. So all these issues need to be discussed, and they need to be planned to discuss and decide regarding the specific genes which should be incorporated in the NGS NBS. And of course, the risk of overdiagnosis and overtreatment. Interpretation of data and the storage of DNA is also a challenge. And the other challenge is that most of these healthy newborns, we don't have a population database for newborns. Because in genetic testing, when we find a variant, we compare it with the population databases. And most of these databases are on adult population. So all these issues need to be taken up on. Similarly, certain disorders, the genotype-phenotype relationship is not often straightforward. The same genetic mutation, it may manifest in different ways in different individuals. For example, Pompe disease, there is a large clinical diversity among the patients with the same genotype. So what we can do, we should keep all this information as a part of the pre-test counseling, at a part of the pre-test brochure or document, and we should make the individuals or the parents know that, okay, if such variant is going to come, we can do these things, and these are the pros and cons. And of course, the issue of variant of uncertain significance will always be there. Now, genotype first approach, because through NGS, we are directly getting the genetic genotype, and the child is healthy at present. So certain more challenges, like not all disease causing variants are known. Still in genetics, nothing is 100%. Initially, it was thought of that intronic mutations are not going to cause mutations, but with the availability of whole genome sequencing, functional studies, even the intron mutations are getting important. So at present, we are not 100% sure. And this genotype first approach might have a lower sensitivity with a wide variance in different populations. Because for Caucasians, for Asians, many mutations which may be presenting in a severe form in Caucasians may not be doing the same for Asians. We have seen. Similarly, also, it may identify the carriers of a combination of variants that might never cause significant disease. So all these issues are very challenging. Data confidentiality is again important. Like if we are going to screen a lot of newborns, we also need to store the data, which may generate a huge amount of information that can be inappropriately used by third parties. Recently, you must have seen, I think, newspaper, it came, one very large genetic group in Europe, or I think US, the data of the patients were stolen. So all these issues are very important, and the issue of genetic discrimination on the basis of a particular mutation, it may affect the insurance and jobs. All these things need to be kept in mind. And of course, when we come to economy, cost of genome sequencing is falling. It is now quite accessible to most of the middle class people as well. But again, genome sequencing at population level is costly for a public health program. Cost of treatment is also high in some of the cases. So we should weigh in the balance depending upon our society, depending upon our patients, depending upon our clients, what they want. Of course, for a family, it will help in early diagnosis, timely treatment, and that is very important for that particular child or the family. Certain legal regulations are also there. If you are going to use NGS for newborn screening, right to privacy, right to free choice, right to health and integrity, storage of genetic information is also very important, and the issues for genetic discrimination. So, and other challenges related to genetic testing, there can be sequencing errors, which may miss out on certain causative variants. And the interpretation of variants in asymptomatic individuals is also very tough, because when we are doing a genetic testing, when we are left with around 100 or 200 variants, we are going to cross match with the clinical features. So that is also a challenge here, because we are testing a healthy individual. We don't know what genotype phenotype we have to do. Then there is the requirement of informed consent for genetic screening, which is compulsory. Training of healthcare workers, of course, we require trained staff for genetic testing. Turnaround time is high. And of course, there are chances for incidental findings or the findings related to late onset of certain diseases. But NGS in NBS is inevitable. Why? Because it helps us in focused screening. What we can do, the challenges which I have told you, there are certain solutions. We can study a restricted number of genes and variants. We can just check for the variants which are pathogenic or known likely pathogenic, or genes which are known to affect the inborn errors of metabolism, and an early intervention can help. So my suggestion is that we can prepare a multi-gene panel including the genes and the known variants. And what is the primary objective? We should focus on identification of highly penetrant disease variants. By highly penetrant, I mean there are certain genetic mutations in various diseases which may not be penetrant, which may not manifest the disease, okay, or which may manifest the disease in a later age. And why by high penetrant, I mean that we are more than 100% sure, okay, if this variation is present, certainly the individual is going to have the disease. So apart from that, preventable or accepted treatment conditions should be there. It shouldn't be like that we have diagnosed the disease and no treatment is there. So all these points should be kept in mind before deciding the NGS gene panel for newborn screening. What we can do? We can make a panel with all coding sequences of certain selected genes, and also we can include the panel of known pathogenic variants. How it will help us? It will help us in limiting the number of variants of uncertain significance. We can make a policy that, okay, we are not going to report the variants of uncertain significance. This will also decrease our time required for interpretation, but it will reduce the clinical sensitivity, because we have also seen many times a patient with lysosomal storage disorder, even the enzyme assay is supportive, but as per the ACMG guidelines, we find that the homozygous mutation is VUS. So that those cases might be left, but still as a beginning, better to focus on the known variations or the likely pathogenic or pathogenic ones. So what is NGS in NBS? It can act as an adjunct to basic DBS based NBS testing, or it can be a first line test. And as adjunct, we are already doing. Any child who is getting a positive result on DBS kit and also the plasma levels are suggestive, next step, we as a lab, we as a doctor, we do advise them to go for a genetic testing to get the exact genetic mutation or to confirm the diagnosis. Of course, this is going to increase the prognostic utility of NBS. If you are starting a NBS along with NGS, of course, it is going to help us. It will help us in pinpointing those screen positive cases which have a mild variant of the disorder. Now, again, a very interesting thing about genetics. Sometimes certain mutations may have a normal course of history, or they may have a mild variations, or they may present mild symptoms in the patient. So all these things will get to know before only. So of course, this will going to surely help the child and the family. And we can even start as a first line test, but it has certain challenges. Data storage, I think already we have certain suggestion. What we can do, we can destroy the data after a few duration of time. And the justification for that is that with every new time or new era coming, new sequencing technologies will come, which will help us in detecting more complete and more accurate data and more inexpensively. So always there is that option. So what we can do? So it is always preferable to simply resequence individuals when relevant, thereby removing many of the concerns of storing the data. We can tell the family, okay, we'll test for these particular genes and variants right now. We'll store the data for 2 years. In future, if your child gets any new symptom, you can again get the child resequenced by the new techniques. That will prevent the problem of data storage. And of course, multiple beneficiaries are there if you are going to offer NGS in NBS, from family to doctors to the society. Now, I've kept this slide regarding 2 studies which were quite famous and which used whole genome sequencing as well as the DBS-based testing to detect certain newborns. This was the study by Bodian et al. In 2015 USA. Around 1,700 infants and their parents were tested for 65 genes, and a lot of variants were found. The true positivity rate was 89%. So basic thing was that around 35, when these families were followed up, around 35 children were found to have certain inborn errors of metabolism. The traditional NBS by DBS identified 34 of them, but the whole genome based technique identified 32. The 3 cases which were missed by genome sequencing were a child with ALCAD or the trifunctional protein deficiency. In that, as we know, that it is caused by a homozygous or a compound heterozygous mutation. But in this case, only a single hit mutation was identified. Similarly, for hypothyroidism, one de novo VUS was identified, which was filtered out because their initial policy was that we will only report the likely pathogenic or the pathogenic ones. Then there was a case of salt bursting CH for which no variant was identified. Probably Sanger or something could be done. But what the authors concluded was that a combination of both NGS as well as NBS is highly synergistic, and it will improve the diagnostic yield and refuting the false positive results. One more study was done by Bomer et al. In 2017, and whole exome sequencing was performed on DBS kids, and 15 cases of IEMs were identified. Which I have seen, like PKU, propionic acidemia, and all these have certain treatment, and the children were able to do good. And the DNA in DBS is quite stable, and analytical validity is independent of the baby's age, condition, or feeding. There were certain challenges for the bioinformatician, like there can be coverage fluctuations between regions for the DNA from DBS. There can be difficulty in identifying certain insertion deletion mutation, but of course with time, with the coming up of good bioinformatic tools, all these disadvantages are gone. Now, in this slide, I have kept a case for you to make you understand the importance of that extended NBS. This was a child who was referred to me. This child, you can see, he is not having any dysmorphic feature. Just he was having involuntary movement seizures. He was having a poor growth. Language delay was there, and the child was very hyperactive. And he was already being given levetiracetam and clobazam by the neurologist. And in the history, there was query history of delayed cry. So basically, this child was tagged as a case of spastic cerebral palsy or post-birth asphyxia sequelae, which we do most of the times as a pediatrician. भाई बच्चे ने रोया नहीं, सीजर आ रहा है, इसको तो CP है. Then what we did, as any case, we did the family tree, we did the 3-generation analysis. The child belonged to a consanguineous family. Of course, head circumference was on lower side, microcephaly. He was hyperactive. And other investigation and in general examination, mostly he was having the spasticity and extensor plantar response. Otherwise, there was no similar any other history in the family. Routine blood test was normal. MRI brain was showing a thinning of corpus callosum. But then I offered this family a DBS testing by TMS, and then I added that testing with plasma amino acid level analysis, and what I found was serine and glycine were quite less. And even then I did the CSF serine and glycine, which was also decreased. So my provisional diagnosis was a disorder which might be related to serine biosynthesis. And then when I added this patient with an exome sequencing test, I found him to have a mutation in the phosphoglycerate dehydrogenase gene deficiency. And this is a autosomal recessive inheritance, and the variant was pathogenic as per the ACMG guidelines. So now some may say that कि आपने क्या किया, आपने तो बस DBS किया और genetic testing exome करके अब क्या फायदा? So now comes the advantage. When I reviewed the literature, I found that this can be treated with supplementation of serine and glycine. Basically, the thing which is deficient in an inborn error patient, we started the supplementation. And the cost was also very less. It is around 2,000 rupees per month. And the good thing was that within 3 months of the starting of therapy, seizure stopped, hyperactivity is decreasing, and gradually now he's in follow-up for last 2 years. I have stopped all the anti-seizure medications. But still the child is not completely normal. He is still having developmental delay. So where we failed as a society or as a doctors, if this child would have been given the option of extended NBS at his birth, he would have been diagnosed at that time only. And if we would have started serine and glycine supplementation since his birth, he would have been completely normal. So as a society, we may not care, but for that family, this child is important. So an early diagnosis is surely going to help us in achieving a normal child. And by this case, I want you all to understand that most of these inborn errors of metabolism are treatable and they have a very cheap treatment. And then there are certain cerebral palsy mimics. If any pediatrician colleague is in this seminar, then I can make you understand like certain spastic CP. These are metabolic disorders which I have kept in this slide. They may present with dystonia, some may present with ataxia, some may present with spasticity, and most of these can be diagnosed through an extended NBS or a NBS including the amino acid profile and the acyl carnitine profile. So what is the take home message? My take home message for you all is that catching something early is always better. Of course, no screening test is perfect. There can be chances of false positive and false negative. And if we have a detailed or a universal screening program for at least basic 5 or 6 conditions in our country, it of course going to do a good rather than harm. And one thing is very important, do follow up the babies who are screen positive, and do encourage the families to get a genetic test or a molecular confirmation. And most of these cases have a multidisciplinary management, which includes physician, field worker, the lab people, the pediatrician, and the metabolic specialist. Thank you.
Thank you, Dr. Mayank. That was very comprehensive. You covered the burden of genetic defects in India, how it is more common than what we assume it to be, how there are many conditions that are easily treatable, and treatment needs to begin early. Treatment needs to begin early before there is irreversible damage that is done. You also highlighted sample collection and special considerations. This is important because there's a limited period during which the sample can be collected, and being a diagnostic chain, it is our responsibility that the sample is collected rightly so. You have also highlighted the way forward and what's new and how NGS can be used, how to design panels, what are the ethical considerations and what are the limitations to it. So I think we are all very well informed on it, and each one of us should become advocates for newborn screening in our own way. As we wait for universal screening to start, for the government to do something formally, in our own way, we too should become advocates for newborn screening. There are a few questions on the chat, and we will take them up now. The first question is from